Oh, hey Chris.
Hey Chuck, how are you?
I'm really good. We're here together early on a Friday morning, getting ready to go to the OR.
Nothing like a little podcast before a big OR day.
Absolutely. Do you have a big one?
Hey, I can't say, but it's not a small case. Put it that way.
Excellent. Well, I hope you make our fellowship recruitment dinner tonight.
Oh no, I will. We didn't put we intentionally did not put a free functioning gracilis today, for that reason. So
Excellent. I have little finger fractures to stamp out, so I think I'll be fine.
good. Well, you can hold down the fort, but I'm sure that we have tried our best to make sure that we are set up for success. Yes, it's fellowship recruitment weekend, so we're really excited about it.
Absolutely. We have a great day of interviews scheduled, a great dinner tonight, as mentioned. Yeah, should be fantastic.
Yeah, by the time this episode drops, everybody will have already come and gone from St. Louis. I'm hoping that in the traditional Washi fashion, it goes off in the way that we expect it to.
Absolutely. And the weather is cooperating. It is unbelievably, unseasonably warm, which we'll take every day.
This is pretty standard February in St. Louis for anybody listening. I hope when you're listening, this is a pre-Super Bowl or right after the Super Bowl. I guess this is going to drop on Sunday, so it's going to be a beautiful, fun weekend here in San Luis, as they say.
Absolutely. So any reader or I should say listener submitted questions?
Yeah, we have a great question to kick off the episode. This is from Chris Gayton. Dr. Gayton is from Myrtle Beach, South Carolina. He says that he's actually listened to every episode. So thank you, Chris, for listening to every episode. And hopefully you're not tired of us yet. But question is, how do you position for cubital tunnel cases? This is, sometimes not a favorite surgery for some because you're uncomfortable against a stretcher and trying to see under the elbow, especially when the shoulder doesn't rotate. So, Chuck, what are your thoughts on this?
Yeah, unfortunately, as I mentioned, I've had a fair number of these procedures lately, and I think of you always as I embark upon them. There are certainly those patients who lack external rotation, and that makes it really tricky. Thankfully, many of my patients are younger, and that is less commonly a problem. To be very kind of straightforward, my patients are supine. I make a massive towel bump that I put under the elbow in maximum external rotation of the shoulder, and that seems to work well for me. I will occasionally do transpositions in a lateral decubitus position over an arm holder when I'm performing arthroscopy in the same patient or if I'm doing something with the olecranon fracture, for example. But typically, supine, external rotation, big bump. What about you?
And that's the same positioning for a straight in situ decompression and for a transposition.
Yes, every time I do an in situ, I am prepared to do a transposition. And as we have discussed, I do fewer and fewer in situ decompressions. Again, partly because of my age, the age of my patients.
I was gonna say your age. We don't need a special counsel talking about your age. So, for me, I think it tends to be very similar. Totally understand. I do have a broader age range in my practice than Chuck. The shoulder external rotation thing is an issue, and you could go so far as to even check it before surgery. I think I have seen some folks who are doing these in the office, do them with patients prone, doing wide awake in situ decompressions. Not my favorite thing to do. Occasionally we'll have to do, like you said, a in situ decompression or an ulnar nerve transposition when someone's positioned for another procedure like an elbow arthroplasty where they're lateral or even prone. And it can be a challenge, just because you're doing what I think is a relatively routine and honestly one of my favorite surgeries, upside down. And it can become a little more challenging. But I think if one were to routinely run into this, I think positioning prone and just having the arm kind of hanging off would be a very reasonable thing to do. I think in terms of if you're going to stay supine, I don't mind being against the stretcher. I think just shifting them all the way over to the side of the bed ahead of time, which is probably not anything novel or new. And then I prep the same way for a transposition that I do for an in situ, just because you never know. Um, I like to do a sterile tourniquet just to not lose any potential room around the elbow, which does give you a little more maneuverability to put your bump in. I remember one time in residency working with Bob Hotchkiss, and he was big on the sterile tourniquet because you never want to get boxed out on your draping for an elbow, any elbow surgery. So even for an in situ, and just for ease of OR setup and the team that I'm working with, same way every time. sterile tourniquet, and get the sterile drapes as high as you can before putting on that sterile tourniquet. And then it is very similar, an entire stack of blue towels, Coban wrapped around it, that sits under the brachium. And it's you have to position it so much so that you can have it at the very edge of the medial epicondyle so that you can work underneath it. If you're watching on YouTube, I'm trying to illustrate that, but be able to work underneath, because if the bump shifts out here, then you lose the ability to work down in that plane. So even if they're not fully externally rotated, you still have that ledge. So if anything, building up that bump more. And then if we're doing a transposition, I typically have them have a separate bump that can hold the elbow in a semi-flex position just to free up somebody's hands. And for us, that used to be what we would call the Johnson bump, back from Jeff Johnson in Pod 4, which was a rolled sheet that they would then cover and sterilize, which apparently is now illegal. So now it ends up being either some kind of big, bulky Jones cotton fluff that they would use as a dressing for somebody else. But that's probably way too much detail. But I guess if you're asking this question, you want details.
Yeah, and just for a difference of opinion, I absolutely never use a sterile tourniquet, ever. I don't find the need. I've never been burned. I do a lot of elbow surgery. So different ways to approach this for certain, but I think the general principles are the same. External rotation, big bump, good exposure, and there you go.
So coding question also from Chris. Is there a CPT that you add to the cubital tunnel code for when you're doing your subcutaneous adipofascial fat flap, and then for a submuscular transposition? I will preface this answer by saying we are not here to give coding advice. We can only tell you what we potentially would do here. Coding is up to the physician and their team, and all of the liability that comes with it is up to you.
That does sound like a legally advised response,
It just
which
seems smart. I don't know. I can't
it
give coding advice, but we're going to say what we do, maybe.
Yeah, well, I would say that, we use the standard 64718 for transposition or decompression, and I cynically believe that's why decompressions took off, because you're talking about a 10-minute surgery versus at least a 45-minute surgery for most. I do not add a code for the fasciocutaneous flap. I do add lengthening 24305 for the flexor pronator mass when I do a submuscular. So for me, it's either a singular code or for submuscular, the two codes. What about you?
Same thing for a submuscular, because it is truly a flexor pronator Z lengthening. For a subcutaneous with the adipofascial flap, I have been listing it, and then actually, before Chris sent this question, I actually had asked our billing team to look, because I do request that they add a code, and I had 15740 because it is technically a pedicled flap from a known vessel that Dr. Yamaguchi described for us. So, and looking at for us and our experience, again, only us, it is a code that is reimbursed at the similar rate, both in terms of how often it is actually paid, just binary, yes or no, and then the actual collection rate is similar to when I asked the same billing team to look up the Z lengthening code that's put in addition to 64718.
Nice to hear. Great question. And maybe I just learned something today.
I don't think you did, but I am very proud of myself for doing some coding work. I never do this stuff, but I did start to think about it. And a question from a former fellow, Andrew Sobel, preceded when I did that. And then this perfect timing, Chris had the same question. So thank you, Chris, for the question. Really appreciate it. Hopefully it was helpful. Certainly email us back if you have any other follow-up questions. And for anybody listening, we love listener mailbag stuff. So handpodcast@gmail.com. So with that, we should thank our first sponsor.
Absolutely. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand.
So I've done a lot of cubital tunnel surgery lately, and I've done a lot of revision scaphoids lately. What have you been busy doing?
A lot of distal radius fractures, as we talked about from the
Yeah.
last episode. I've had a pretty good mix. I've actually the last few weeks been very happy. I have hit the hand surgery triathlon. I don't know if you're familiar with this concept. Our fellow Emily Zoldos had not heard that term, but using the fluoroscope, the microscope, and the arthroscope in the same day.
That is a new one for me. And it does not sound like a good day when you throw in the microscope.
Oh man, I love those days. For me, that's the best. And again, the arthroscopy does not come up that often for me. I'm, kind of uh, general hand surgery level arthroscopist, certainly not a master like Chuck. But it's a nice thing to do, and a nice thing to offer, and I love having that. I know that you don't technically have a microscope at the main facility that you work at, so perhaps that is limiting your participation in the hand surgery triathlon.
It makes me laugh at myself because my children often give me grief. And the old man's triathlon, sometimes I participate in at home, which is rowing, biking, and lifting. And so they laugh at me when I do the old man triathlon.
That's a pretty good triathlon. I mean, come on, you're about to have a partial knee replacement. What else can you ask for?
And you got to be able to laugh at yourself. I like the concept of the D triathlon. I like
Yeah,
that.
so it's been relatively busy, steady. It's been good. It's as I think what we talked a couple weeks ago was getting a little bit too much, but now things have quieted down. Have a nice OR day today, nerve surgery, more relaxed, less running around, and a distal radius fracture to fix in the afternoon. But
Yeah, I wish I could agree with the calm down. It has not at all, but maybe it's because I'm about to go out for a little bit of time next week with the small surgery.
yeah, well, there you go. Good luck to you on your surgery. Can't wait to hear you hopped up during your recovery. My wife has advised me that, we talked about this on prior clinic or prior episodes, but I need to stop scheduling the makeup clinics because I think that is that's what's been hurting me, and it's a very hard thing to just let go of that. But I think I'll follow that advice.
It's good advice, but it's just hard. I mean, you hate to make patients wait or not see them in a timely fashion. And I had a very it was going to be a very short afternoon clinic yesterday, and it was a large number of patients, and they were quite complicated, and it was very frustrating. I haven't been frustrated like that in clinic in a while, but I think the key is knowing what you're going to see and planning ahead, but it's not always easy to do.
Absolutely. So, but before we get into this Volar scaphoid technique kind of deep dive, why don't we thank our other sponsor, Checkpoint Surgical.
Absolutely. The Upper Hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery.
Checkpoint's next professional education program, Upper Extremity Acute Nerve Injury Management, will include an overview of intraoperative ultrasound imaging to augment nerve zone of injury assessment. Now, that sounds really cool. The program will be led by Luminary faculty, Luminary, nice, including doctors Deanna Mercer, Amber Lease, and Brooke Baker, and takes place on March 15 and 16 in Scottsdale, Arizona. Now, that sounds really good. To learn more about this and other educational programs sponsored by Checkpoint Surgical, please visit nervemaster.com. Checkpoint Surgical, driving innovation in nerve surgery.
They really are hosting some really good courses. I have to applaud the efforts.
Yeah, and I think intraoperative assessment with ultrasound is really cool. I mean, I've done that on a handful of times, and it's been helpful. And certainly not a skilled sonographer just yet, but even in novice hands, it can provide useful information. And it's not as limited by things like the tourniquet, which can be an issue as you get later on into a case. And Checkpoint's also helping sponsor our WashU peripheral nerve course. For those of you watching on YouTube, here's the flyer, April 5th to 6th, here in St. Louis. Keynote speaker Susan McKinnon. We really want everybody to come and check it out. Ortho, plastics, neurosurgery coming together, I think, for the first time in WashU history to host this meeting, and hopefully the first of many. But some great sponsors, including Checkpoint. I'm trying to wrangle Practice Link into exhibiting. So anyway, please come check us out. I think it'd be a really fun meeting. Registration's open. I think there are still some spots left, but if we tell you the spots are limited, maybe you'll be more interested. So check it out.
Move quickly. You will not, I will not be fighting you for a spot in this course, even though I think it'll be a fantastic course. That's too much nerve for me. Too much nerve.
That's okay. All right. So tell me a bit about some of these revision scaphoid cases that you've been doing. That sounds honestly quite awful from my perspective. But it is such a technically demanding surgery, both in indications, selecting your surgery, and then the carpentry and the plumbing, for lack of a better term, can be really quite tough.
Yeah, it's interesting. I always try to understand, and so I have two cases, and I'll just briefly give the highlights, and then we can talk about the technical and the revision setting. One of the cases was apparently, after in speaking with mom, this is a 16, no, I'm sorry, an 18-year-old who was treated out of state and had initially apparently been treated for a scaphoid nonunion from a volar approach with 2 micro but they then removed one of the microacutracts at the time of the original surgery, leaving only 1 microacutract in a sizable patient. And I guess honestly, not surprisingly, the bone didn't heal. So that was
So
an
do you feel like what's the right size screw? Whether it's a Accutrack screw or not. I mean, those micro type screws, two is okay if you've got two of them, right? Is usually one is unless they're quite a small patient, one probably is not enough unless it's backed up with KY or something or
Yeah, I haven't seen any anatomical studies, or biomechanical studies, I should say, but 1 microacutract for a waist non-union in a standard human being is, in my mind, is probably not enough. For me, it's almost always a mini sized. And occasionally in a revision, I'll do a standard, but a micro is tiny. It looked tiny, it was tiny, and the bone didn't heal.
so I guess the basic hand surgery and orthopedic principles when you're thinking about a bone not healing, is it a blood supply issue for this bone? Is it lack of inadequate immobilization of the bone, either in some settings, casting versus fixation? Is it infection? Like, what's your thinking just for the very basic people maybe that are earlier on? How do you approach this in terms of how to figure out what's going on and what you can do to make it better?
Yeah, and let me briefly highlight the second case because it gets to one of your points. The second case was also a waist non-union, and patient had not previously been treated and was treated with a vascularized bone flap, um, which in retrospect and for me, it just wasn't necessary, and I think it compromised the carpentry, so to speak, and the fixation, which led to another non-union, a non-union of the non-union. So I think that from a basic principled standpoint, waist scaphoid fractures should typically heal. They are rarely compromised by blood supply issues. And so we, as surgeons, when we approach these, need to restore the anatomy, ideally apply a compressive screw, and add bone graft if necessary, which in a non-union, it would be necessary. But those are the simplistic, basic concepts.
Right. And you say here that, just to clarify, you say that the blood supply is rarely an issue, but that is the textbook concern for at least any scaphoid fracture, more relevant for proximal pole fractures as opposed to scaphoid waist fracture. I just want to make sure that that distinction is made for those that are listening. Is that an accurate summation of what you're saying?
Yeah, so the scaphoid blood supply comes in distally and travels proximally. Therefore, the further proximal the fracture line is, theoretically, the greater risk of a blood supply compromise and an avascular necrosis type situation, or simply a non-union. I'm just my point earlier was simply that I don't recall real blood supply issues for any waist fracture.
Right.
It can happen, but really we think about blood supply issues with proximal pole.
Right, right. And then I guess your other point that I wanted to expand on a bit was saying that these non-unions, in the setting of no prior surgery, typically, they don't typically require anything more than good fixation and some cancellous bone graft. And I think with all the excitement that there's been with various pedicled bone flaps and then subsequently free, cartilage type transfers, vascularized free flaps essentially of bone, there's been a bit of a pull back. And I think there's been some evidence suggesting that you really don't need much more than what you described in terms of getting good compression for the first, surgery for a non-union, adding some cancellous graft. Would you agree with that?
Yeah, and the technical part, and this has been demonstrated biomechanically out of Seattle, is you want your screw center in the axis of the scaphoid. So center on the PA, center on the lateral. And in both of these cases, these revision cases I just did, the screw was far from the center axis. And sometimes it's difficult to place that screw exactly where you want it, but it needs to be pretty close or exactly center to maximize the patient's chances of healing. And so, not overdoing concepts like vascularized bone graft and focusing on the basics, that is, make sure if it's a non-union, you debride the non-union site, you add cancellous bone graft, and you put a good screw in.
So for for you, when you talk about the approach to something like this, when do you need something more is one question. And then the second question is you talk about being center, but there are some, fractures that are in non-unions that might be the exception to that rule where you want to be more perpendicular to the fracture itself as opposed to being center to maximize fit. So can you talk me through when you need something more, but maybe answer the second question first, because that might be more direct.
Yeah, so there is a higher rate of non-union for oblique fractures, and that's pretty well established. And it is a little tricky to decide when do you want center or when do you want your screw perpendicular. I think if you can have a good entry point, that is an appropriately placed starting point, and you can create a screw trajectory which is perpendicular to the fracture line, which allows compression. I'm not against that by any stretch, and that would be for the oblique fracture pattern. For most other fracture patterns, center. That's my approach.
Yeah, and I think that's where those micro screws, or at least the smaller diameter screws, can be really kind of useful to accomplish that. So then, but to get into the second question, I just want to say, you know, there's the scaphoid non-union that presents after inadequate immobilization. Either, it's a missed fracture, or they've had casting and it's just not enough. And then you're looking at screw fixation with some graft, perhaps, cancellous graft. That's a separate entity than what we're about to dive into now, which is the patient who has had surgery and now has a non-union after an attempt at surgical treatment. So is that a fair way to set the stage for the rest of the conversation?
Yeah, it's a fair way to set the stage. And I would say you had previously also questioned, when do you need more than a screw? Um, and the screws we have to choose from, no matter what the manufacturer is, are really good and really strong screws. I think the beauty of cancellous bone graft is it simply brings healing factors into the area of the non-union without providing structural support. I'm not against structural support, and actually in both of these cases, I went to the crest. I can sometimes use a Rusi technique in some of the volar cortical bone from the distal radius, along with volar cancellous bone from the distal radius. But when I really am worried, I do go to the iliac crest, and one of our partners, Marty Boyer, always goes to the crest. And I don't know about you, I do think the crest is slightly better. I think the bone graft is slightly better, but it's also a bigger deal. So I don't do it often. I just happen to do it twice in these most two recent cases.
Yeah, no, I think the iliac crest is probably the gold standard in terms of structural, either bicortical or tricortical support, depending on when and where you're using it. It hurts so much in terms of, the thing that patients will describe afterwards. And there's definitely some technical skill in terms of how to do it appropriately. And you can obviously get a lot of cancellous too while you're working in those between those tables. Um, I guess one thing is that actually one of these cases was discussed in conference on Monday, and I was the only one that brought up the modified Rousset as an option. So I think that because mainly because you weren't there to bring that option up. But I think the conversation was good about when you potentially go to the crest. Is when you think about when you need more than just a screw and cancellous, is it largely based on pre-op deformity and or the prior surgical approach? And how do you assess the deformity? What's your best way to do that?
Yeah, so I think the simple answer to your question is yes, preoperative deformity sets the stage for what do I need? Do I need more bone graft? Do I need iliac crest? And so absolutely. I'm not someone who always wants a CT scan, although the intrascaphoid angle on a CT scan is most helpful. Plain radiographs will give you plenty of information, especially if you use the secondary indicator of the lunate position. So if the lunate is tilted dorsally, which happens when the scaphoid flexes through the non-union, then that's an indication you're going to have to open the scaphoid to correct the humpback deformity. But it's the humpback deformity, and if there is a humpback deformity, I've not found a way to deal with that successfully from the dorsal approach. So humpback deformities, for me, are always volar. I think most people would agree with that. I think there's some that might try to do this from dorsal. I think that's tricky.
I think that is tricky. I think you can get a little bit of correction maybe from dorsal, but obviously as you're working dorsally and you're getting more towards the waist and you're doing more manipulating, you are getting to that blood supply that Dr. Gelverman very beautifully illustrated, 40 years ago, with the concern about doing too much dorsally. So you can get a little bit, but if you need any real correction, you really got to go volar. And I think that the intrascaphoid angle is a good point for the residents and fellows. That was described by Amadio and, originally on a lateral film, but a CT scan gets you a much better perspective on that. Just making sure you reformat your CT scan appropriately, so request that from your radiologist so you can get a really good scaphoid assessment. So we have to wrap up pretty soon, but can you talk me through kind of your volar approach? I don't think we've gone through that volar approach in detail on the pod.
Yeah, I think it would be good and hopefully lead to some listener questions. So I essentially, if you're on YouTube, especially if you're a younger listener, my finger is on the scaphoid tuberosity, which is just distal to your wrist crease. And so what I do is I have a longitudinal incision of the FCR and then an oblique extension over the thenar musculature. And that gives you great exposure of the tuberosity of the scaphoid and trapezial joints, as well as more proximally. So make your incision. I release the volar ligaments, that is the radioscaphocapitate and long radiolunates for later repair. Repair those on your way out. And it's a sharp approach for me, essentially all the way down to the joint. And then you expose the scaphoid. Do you think about it the same way? Do you do anything differently?
No, I do. I think about it the same way. And I was just thinking, this is an approach where, you don't get to see it enough, I think. And I make sure to tell our fellows, if somebody's doing a volar approach to scaphoid, you should definitely go see that case because scaphoid non-unions are something that a general practicing hand surgeon should be able to tackle. Especially considering the growing evidence that some of the, MFC, MFT things are more narrowly indicated, I should say. So this is something that you should be able to tackle and approach. And I agree entirely with the incision and what you described.
Yeah, and the fiddle factor can be high once you're addressing the scaphoid itself. And so a rapid approach is super helpful because you don't want to waste time with a prolonged approach. It shouldn't take long, but to your point, if you're not doing this approach all the time, then you move a little more slowly. So once things are exposed, old hardware has been removed, whether from dorsal or volar. And I will say that I don't mind going both sides of the scaphoid. I don't think that's a big deal. Ideally, you just pick one side and you go volar in this case. And then it's preparation of the non-union. So that has to be done really well. And I typically put joysticks in the proximal and distal scaphoid. So that's a 0.062 K wire, or was that a 1.1 millimeter or one? Maybe it's, I don't know, but
I think it's a 1.2.
1.2 millimeter. Anyways,
We have a chart. We
joysticks.
have a chart in my OR to convert these things because even the reps don't talk American. They talk to me in millimeters. I'm like, our K wires are actually in standard units. So, but yeah. Anyway,
So joysticks, open up the scaphoid, curette, rongeur, get to good cancellous bone. If you don't do that, it doesn't matter what you do after.
right. So, and you're talking briefly about getting out the hardware. Sometimes if that hardware was inserted in a retrograde manner, are you having to trim back some trapezium, or just in general, if you're putting in a retrograde screw, you do have to take a little trapezium at the ST joint, right?
Yeah, it makes these two cases made me think about how to put in hardware in a way that if you have to take it out, it's not a disaster. And so, yeah, these were both quite challenging because number one, the screws were countersunk quite a bit, and number two, they weren't inserted in what I would say the typical location is. So you have to work a lot harder to identify the entry point. You don't want to destroy the cartilage of whether it's the proximal scaphoid or the distal scaphoid, and it becomes very, very tricky. But ultimately, you have to take out the hardware one way or the other.
All right, so hardware's out. You've opened up, you've got your joysticks, and you've debrided the non-union site. So then we don't have to get into the technical aspects of, we should maybe in a follow-up episode talk about, your approach to harvesting a modified Rousset, or a tricortical or bicortical iliac crest. How do you approach the fixation part of it?
What I think is critical is once you have opened up the scaphoid and placed your bone graft, I like to create the scaphoid as a single mobile unit. And so I do place a derotation K-wire off axis. Typically it's a 0.045. And that allows me then to move the scaphoid as a unit. And the reason that's so helpful is you can put a retractor underneath the distal scaphoid, giving you better exposure to the articular surface at the trapezium, which allows you to put a better home run screw in a retrograde fashion. So for me, that's critically important, and allows just a much more satisfying progression of the steps. Do you do that same thing?
Yeah, I think that's super helpful. I think the rotational wire is helpful, and I agree it does help with the exposure. And what I'm pondering right now is whether I would actually then, after I've gotten that scaphoid in better position, then choose to do a percutaneous dorsal or a mini open approach if I haven't already done that to put the screw from in an antegrade manner. But I guess at that point, if I already removed hardware and kind of gone through the trapezium, it might make more sense to get your home run screw, as you call it, from from distal to proximal or retrograde.
Yeah, especially if your distal fragment is the smaller fragment. In that
Right.
case, obviously you would put your screw in from volar and from distal to give you the best possible stability. But to your point, it's never wrong to go back dorsal. It's easier to put the home run screw in from dorsal for sure. I typically have been a one screw person, and you sort of have to balance placement of the screw without dislodging your bone graft, especially when it's a bicortical or tricortical graft. But that graft is a source of stability as well. And so if you tailored your graft well, if you've done good carpentry on your graft and you put it on the volar aspect of the scaphoid, hopefully your screw starts and proceeds slightly dorsally, but still hopefully in that center location.
Right. As we draw to a close, I mean, you're really hoping for an interference fit of that cortical graft on the volar aspect. Question for you: would you ever consider a plate in this situation?
Um, I would consider a plate. I have not placed a plate. I have done K-wire only fixation. I don't love K-wire only fixation, but again, if you've done your carpentry correct and you have good press fit, in our case, it was bicortical iliac crest. I don't think it's crazy to stick to K-wires if you can't get a good starting point because of a previously placed screw, which makes everything more challenging. So it can be really tricky in these revisions with hardware removal. A plate is not a bad idea. And I would probably stick to a a 2.0 plate or something like that. But I don't have any personal experience with plates. Have you done plates?
Haven't. I know that there is one manufacturer that does have a scaphoid specific plate that's been talked about quite a bit and published about quite a bit. I have not yet, but if I were to, that might be the one situation in which I would consider this. If it does help, obviously secure the location of your carpentry. So that was fun. If listeners, if you want to hear more about Chuck's adventures with revision scaphoid and get into some of the weeds and details about the country stuff, let us know. Or if there are any other questions, feel free to send in suggestions for topics, and look forward to catching up soon.
Fantastic. Great to see you. Have a good day. Enjoy those nerve cases.
You too. Enjoy your case.
All right. Take care.